Recording in progress.
Okay, week 7. So you'll notice that in 300, we're really starting to dive into what we're really going to be doing in the operating room. Okay, but I did want to go over this one question that was missed so that we can kind of like, if you see this concept again, then you'll know, okay, this is what they're talking about. Okay, so the question asks, what is the correct guideline for surgical skin prep? I want you to think back to when we did this live session. I think it's last week, right? Are we prepping a tiny exact spot or a larger area? Right, it's a larger area. Okay. Now, because the surgeon may extend the incision or even need additional access during the procedure. Okay, so that's why we're not going to just do that incision site. Remember, I gave the example of, like we are doing um, like a laparoscopic case, right? And you have like just a small incision site, but we're still going to prep the entire abdomen because you just never know. Okay. Now, when we prep the skin, do we start dirty to clean or clean to dirty? Because that was another concept that I saw. Kind of just be thinking about it. Would you want to start at the contaminated area and then go in, or do you want to start at the clean area and go out? Exactly. Clean to dirty. Okay. Now, one of the big things about this concept, because they're going to throw it at you a lot of different ways. Okay. We're always thinking about patient safety, especially during the surgical procedures. So the final questions usually get um, to start thinking, if you see this concept again, about like extending incisions. So even if they're talking about, okay, we're doing an open appendectomy where we just have the one incision, let's say they get in there and somehow this particular doctor is going in and he nicks something else. Well, now that smaller abdominal appendectomy incision now has to be extended. Think about contamination risk. If we only prep that one little incision site and now we have to extend it, think about what would happen. Sometimes we may have to reposition. Um, a lot of times you may have an unexpected procedural change. And again, it all comes down to what we do not want. We do not want surgical site infections. Okay. Does that make sense? Because you will see this concept thrown a lot of different ways. Okay. So I just kind of want you to think when they're thinking about incisions, no matter what they say, you're always clean to dirty and you're extending it wide. Okay. So that you don't contaminate, or if you have to do an additional incision on top of what we're already doing. Okay. Now, again, we have 4 videos this evening. So I get kind of excited because this is where y'all get to start seeing exactly what we do. And keep in mind, we're at week 7. In 7 weeks, literally, you're going to be actually in the lab. I know you're going to the lab before then, but I mean actually hands on in 7 weeks. Think about that. In 7 weeks. Am I counting right? 4, 6, 7 weeks, right? Because you have the 4, the 2 weeks off, and then 7. Yeah, 7 weeks. Okay. So we look at the image, all right? It's an empty sterile field, okay? Instruments are aligned, your lights are focused. FYI, there are light handles on here, so those are sterile. We can manipulate them, okay? This is where trust lives, all right? The line between clean and dirty is obsolete. In sterile technique, there are no gray areas. So those questions that you see, they're literally, is it sterile? Is it not? Does this protect patient safety or it does not? Okay. The reason I say that is because I want you to think about what would happen if the line was blurred. Contamination, infection, surgical site infections, patient can become harmed. One small break can become one major complication. So, in this particular chapter, we are described as the guardian of asepsis because we maintain the sterile field, we protect the patient, we prevent contamination. We are that final barrier between microorganisms and the surgical site. So, we're going to understand why the rules are so obsolete this week. Keep in mind that sterility is binary, sterile or not sterile. So let's get into it. Okay. So we look at recognition and action. So we kind of dig back from our micro days. Okay. Over here, we have that good old Staphylococcus aureus. Over here, we have a surgical site incision. What is the only thing standing between them? What's the only thing? Think about what we do. Think about some of the things that you're already taught. Aseptic technique, most definitely. What about the field itself? Does that sterile field help hopefully keep that staff away, right? We as the surgical team, all 12 of us, we're the surgical team. And then we get another shout out as the CST. Now, it is about training your eye. Once you guys get into the lab, you're going to know exactly what I mean. You're spotting contamination. You're like scanning. You're noticing those breaks. You're seeing those subtle errors. You're watching hands, making sure that no one's touching, coming near. Think back to that video of week 1, right? How we would have loved to throw that individual out of the operating room. Well, in real world, it's not going to be as obvious. There'll be slight subtle that you're just noticing and you're like, oh, I got to change gloves, or hey doc, stand back, I need to change your glove, or I need to give you a sterile gown or a sterile sleeve. Okay. Sterility fails quietly. It's not like that guy that we saw day 1. Now, if someone reaches across that sterile field, what must your brain do instantly? You're scrubbed in, and someone who's not scrubbed in is like, hey, I need to kind of reach over really quick. What is your brain already kind of like? You can stop them, but you got to keep in mind, you're still sterile, but you're already thinking, right? We're recognizing that, hey, I need to stop him. So you're recognizing the risk. You're evaluating the contamination, and you're speaking up. Yes, most definitely. Recognition will start to become just automatic. It's like muscle memory. We're learning it here. In 7 weeks, you're going to be practicing it. That way, when you get into your clinicals, it's automatic. You're already like, hold on, wait a minute, stop. The mission is to apply surgical conscience to every single moment. But we go back to what exactly is that surgical conscience? In your own words, type what surgical conscience is. Doing the right thing, speaking up when you know something isn't right. Most definitely. What else? Integrity and honesty to admit when there is an error. Yes. Surgical conscience is the ethical standards and being the advocate for the patient. I love this. Also, if there is contamination, accountability for your actions. I was getting ready to go there. Admitting when there's contamination. So most definitely, yes. It's everything you guys said is integrity in motion. Okay. Now, if a non-sterile object brushes the sterile field, we're going to consider it contaminated. We're not even going to think. We're like, oh, this is contaminated. I've got to replace the item. Notify the team. There was another question that I kind of wanted to hit on because it was a little bit ambiguous. So the question was about the drapes. And from the videos, you guys know that when you place that drape, you leave it. Okay. But here's another added step. Okay. And we're tightening up the wording because the answer is still correct, but we're tightening up the wording because let's say you've done it, you've draped, right? But now there's contamination on the drape. And that was that missing piece, that missing word. So what do you do then? Well, then you would have to have it discarded, or in some cases, real world versus the book says you discard it. Okay. Real world, a lot of times we have additional drapes that we can place over, but real world versus the book. Okay. We're always going to go by the textbook. Okay. But I didn't want to kind of bring that up because if you do see that concept again, I want you to be like, okay, wait a minute. Are we at the beginning of the draping where we drape it, we place it, or did something happen? Okay. It's one of those when in doubt, throw it out. Okay. Now, the other thing about these surgical sites, infection doesn't just happen in a single dramatic motion. It's not like you see the staphylococcus going through the air and landing on the sterile field, right? It's a lot more complex than that. One, that would kind of freak me out because I'm like, wait, what is that? Okay. So this is why we're training to see what others do miss as CSTs. So when you scrub in 7 weeks, because I'm trying to make it real, right? In 7 weeks, you're not just setting up instruments. You are standing between this microorganism and this very vulnerable incision. Okay? Remember that line is obsolete. So the principles of sterile technique, another concept that comes up a lot. I want you to focus on this highlighted area right here. Okay? This is where sterility exists. We're looking at the table level within the draped field. Sterility exists only at the table level, okay? Not below. I have seen this come up. Not outside, not assumed. We got to talk about barriers. Our primary barriers are physical, okay? As CSTs, what are some of the physical barriers that you've read or that you even know that help protect the patient and us that we deal with? Our PPE, yes, gloves, gown, drapes, okay? Their chemical separation, skin prep, antiseptics. Barriers create separation between contamination and sterile zones. If a sterile glove brushes against a non-sterile IV pole, it can happen. Is it still sterile? Right, it's not. Because contact equals contamination, full stop. Okay? Another thing the chapter brings up is that spatial awareness. I have seen this concept come up. We look at the 12-inch rule. Okay? What can someone tell me about the 12-inch rule? Because this is going to be one that's really going to affect you guys in the lab as well. And you can look it up. I want you guys to know you can look it up. Okay. 12 inches from table is the sterile field. So that means that we're trying to maintain, and that's correct, we maintain 12-inch distance from non-sterile areas. But why 12 inches? Here's the thing. The theory is it reduces the contamination risk and it gives you like a little movement buffer. Okay? Spatial awareness prevents accidental contamination. There's also that table level rule. Remember, we talk about everything is sterile at the table level. Think about gravity. I want you to think about airflow. Anything below the table, we can't see. It's not being monitored. So the sterile field, I want you to think, is a horizontal plane. It's not a vertical assumption. Now, there are cases where the sterile field moves, right? But we still maintain that table level is where the sterile field is. Now, we talked about passing protocols, and it's really important for y'all to actually see what I'm talking about. Now, the chapter does talking about how you pass each other. But from reading it, did you really get an understanding of like when we say face to face or back to back? Be honest, it's okay. Like, does that make sense? No, exactly. And I love that. So this is why I grabbed this quick little video to actually show you what this means in real time. It's really quick, but I want you to see exactly what passing protocol does look like.
Sometimes as a surgical tech, you need to get to the head of the table. What you don't want to do is walk behind somebody like this, okay? Now what you want to do is use proper sterile technique. Do this.
Does that make sense now that you've seen it, right? Because I was looking at the pictures and I was like, I mean, they're cute, but does that really help, right? So that's how we move in the operating room with sterile to sterile individuals, okay? And you'll notice that he still kept his hands above his waist. And as he moved, he kind of like rolled around and rolled back, but it's back to back. Or if they were face to face, they could do that too because they're both sterile. But if that individual is doing their thing, especially when you're turning over, like let's say I'm coming in to replace Stephanie. So Stephanie's doing her thing, and I'm going to literally kind of go back around her, back and forth to kind of get orientated to the field that I'm going to kind of take over, whether it's a break or if I'm taking over for the day. Okay. And just make sure you're reading up on that. But I wanted you guys to kind of see. So if concepts come up, you're like, I remember back to back and what that actually looks like. The other thing that you guys are going to learn is the amazing surgical scrub, which is unique to any other healthcare individual. Okay. Now, hand hygiene is not a clock-based habit. It's event-based. But what do I mean? It's going to be triggered by actions, triggered by contamination, triggered by contact. Is washing at the start of a shift enough? And I'm going to tell you no, but I'm going to tell you why, right? It's not. I'm going to tell you why. Because contamination happens throughout the day. So we can't just scrub our hands or wash once and be like, I'm golden, and move patient to patient without going back to wash our hands. Now, what events require immediate hand hygiene is before we open sterile supplies, after touching non-sterile equipment, after we've adjusted our mask. Keep in mind, this is before you're sterile, because once you are sterile, you're not touching your face. It's going to be really interesting. Like if you get an itch, you're not touching it, okay? After you're using the phone, after touching, anything. Now, we have intra-case triggers. Gross contamination. Let's say you're going through and you got a break in your glove. You've dropped an instrument. You're touching non-sterile areas. Gloves do not replace hand hygiene, so kind of keep that in mind. So just because you have on sterile gloves doesn't mean that you do not scrub your hands before. And we do it at the end of the case because we're getting ready in some cases for the next case. We are removing our gloves. And in some cases, we're dealing with a lot of decontamination handling. And you don't want to take any of those things home. Okay? So the bottom line, triggers, mask adjustments, scratching your face, contaminating the glove, blood contact, or if you're touching trash. Okay? Like I said, a lot of videos tonight. Another thing that we do is when we're talking about drying our hands, there's a certain way we do it. Drying is not cosmetic. It is contamination control. Water flows downward. So a lot of times when you see us walk into the operating room, you notice that we're walking like this. Well, we're not doing it just to be cute. We're doing it because when we've washed our hands, we want everything to flow downward. Okay? That's because as water flows downward, so does contamination. Okay? You'll also notice how the posture is. When you watch the video, I want you to watch for some things: direction, posture, and I want you to see if you can determine if any errors are there. Okay, so let's watch this video.
Keeping your arms elevated, dry your hands and forearms with the sterile towels in the gown packet. Now you can put on the gown that is lying in front of you, folded inside out with the collar and one of the two shoulder areas visible. Pick up the folded sterile gown so that it can't unfold on its own. Hold it securely in front of you and step away from the sterile area. The collar should be at the top. Now reach into the inside shoulder areas with each hand in turn and hold the gown in front of you with outstretched arms. Stand so the gown can't touch anything when it unfolds. Then, allow the gown to unfold by itself, making sure it doesn't touch the floor. If it doesn't unfold easily, try giving it a gentle shake. Once the gown is fully unfolded, carefully slide your arms into the armholes one at a time. You can slightly raise and spread your arms to guide each arm through the sleeves. Since you're going to use the closed glove method to put on your gloves, make sure to keep your hands completely inside the sleeves for now. Keep them at shoulder height so you don't touch anything and so that the gown doesn't slide back down. At this point, you'll need some help. Ask an assistant to pull the gown all the way over your shoulders and to help fasten the back and waistband. Keep your fingers inside the cuffs. Now we'll show you the closed glove method. First, unfold the sterile paper package and press the edges down so they don't fold back again. Grab the right glove with your left hand. Now place the glove on your right palm, flipping it over so the fingers point towards you and the thumb is on the correct side. With your left hand, pinch the part of the cuff facing up, and with your right hand, pinch the part of the cuff facing down. Next, use your left hand to pull the glove over your right hand and the gown sleeve. When you pull back the gown sleeve, the glove will pull back with it and let you slide your hand into the fingers. Done! Do the same with the left glove. Turn it, put it on your left palm, grab part of the cuff facing down with your left hand and the part facing up with your right hand. Pull the glove over your left hand and sleeve, pull it back with the gown, and slip into the glove. Finally, the surgical gown has to be secured. If you'd like to look at this straight away, just skip to the last section of this video. Otherwise,
And we will do that. So one thing that I want you guys to notice. So they didn't spend as much time with the drying part that I would have liked. So when you grab the towel, you're actually bending forward. She didn't bend forward as she's fine. There's that gray area, but you want to bend over enough so that you're not contaminating. And you're literally, and if you guys watch how my hands are doing, I have one towel. I'm going to use my scarf because it's kind of colorful and hopefully it shows up. So you have your scarf or your towel, okay? And you're taking your hand and you're doing like this. So all the way down. Then you take the scarf, I don't know if it's not showing, and you reach underneath and then you do it for the other one all the way down. Okay? And you're doing it at an angle. So you're bent not this far because I'm not really sure, and your arms are still up. Okay? And then once you've done that, then you go and grab your gown. Does that make sense? Okay. They're going to definitely show you guys step by step in the lab, but I want you guys to visualize it. So if you get these concepts, you have an idea of what they're talking about. Okay. Like I mentioned, we have some videos tonight. All right. Now we gown and glove the surgeon, residents. Sometimes we gown and glove each other. So let's say, I am relieving Andrea and she has extra gown for me. So she can actually gown me CST to CST, okay? Now, when you guys watch the video, you'll notice how we get ourselves sterile. You'll notice how we gown each other, okay? So let's take a look.
we'll first look at how the whole thing works when you have an assistant to help you gown and glove. The sterile gown will often already be held open for you by an assistant after you scrubbed in, especially in the OR setting. All you have to do is slip your arms into the sleeves, and the gown is pulled up over your shoulders and closed at the collar and back. The wrists should remain covered by the gown. Keep your hands in front of your chest so you don't accidentally touch anything and the gown doesn't slip back down. Now it is time to get your gloves on. The assistant will often stretch the right glove open for you so you can easily get your hand in. Slide your hand in with the thumb adducted, then spread your fingers slightly. The assistant will then pull the glove all the way over your wrist and the gown sleeve. Next, the left glove will be handed to you. Stretch the cuff open with your right hand and pull it on. Again, keeping your thumb adducted initially as you slide your hand in. Now, secure the gown. The technique is always the same, whether you have self-gowned or gowned with assistance. Grab the paper tag hanging at waist level and pull off the left tie. Hold that tie firmly in your left hand and hand the paper tag to your assistant. Then do a counterclockwise turn, making the tie close the gown. Grab the end of the other tie, taking care not to touch the tag itself. Pull the tie off the tag, tie a bow, and your gown is secured. Now that you have your gown and gloves on, it's best to keep your hands clasped to your body at chest height while you're not actively using them. Great! Now you're fully gowned.
All right. Now, this question has never come up, but we just talked about passing each other, right? Did it seem strange that one was able to spin in front of the other one? Right? So keep in mind the distance. When we're passing each other, we are kind of literally like right near each other. But when we are spinning or dancing is what we say, dance with me, you're at a good distance. So she's not spinning right up on her because that would be contamination. Also, a lot of times your circulator can be the one assisting, either like in the very first video we saw where the circulator kind of helps and ties the person up. So the same thing can happen. The biggest thing is keeping that distance so that you're not right on top of each other. Okay. Also, one thing that gets the students in the labs is those thumbs. So when you are opening the glove for the other team member, watch your thumbs. I'm very sneaky to the point where I will easily kind of, if I see a thumb out, I may grab it and then you're unsterile. Not to frustrate you, but because it can happen. You may get that resident or that nursing student or even someone who's new to the operating room, and they may unintentionally contaminate you. Okay, so if you don't remember anything about gloving someone else, just kind of remember, I got to make sure my thongs aren't exposed so that there would be no potential for any type of contamination. Okay. Now, if the surgeon reaches prematurely during gowning, keep in mind, we as a CST, in this instance, we control the pace. Okay. We have verbal cues. We have controlled movement, and there are clear instructions because we are the subject matter expert when it does come to sterility. So here's a question. If the glove rolls and exposes this cuff, okay, so it's rolled down and now the cuff's exposed, what should we do? What can we do? Think about what you have at your disposal. You have your circulator. Can I replace my glove? Yes. Okay. You can replace your glove. If, let's say, the gown sleeve slides down, so now you've got shoulder exposed, and whatever was non-sterile is now flipped over, what would you do then? Yes, regown. If the surgeon grabs the gloves improperly, stop and reset. Hey, doc, hold on. A lot of times as a resident, I'll be honest with you. Hey, doc, hold on. I got you. Okay? Because at the end of the day, we're trying to protect our patients. Okay? Protecting the team protects the patient. We are that last checkpoint before that incision starts. It's us. Okay? So, we're in a case. And this is very important because I have seen students like they contaminate their gloves and they instinctively want to change it. But keep in mind, you contaminate this glove, you grab it with your sterile hand, what just happened? Now you've got two contaminated hands. So this video shows us what to do when removing a contaminated glove during the case. Sometimes before, but a lot of times during the case.
Okay, so now if you contaminate your glove, you accidentally touch something, again, every time something is contaminated, you announce it and hold it away from you. So instead of you removing your contaminated glove yourself, because you will then contaminate your other glove, your circulator, the non-sterile person, will remove it. The first thing they're going to put on, though, is exam gloves, because they don't want to be exposed to what is on your glove, because you've been touching the instruments that's been in the patient and things like that. So they're going to present their hands, if it's one or both, up like this. So your circulator is then going to grab only on the glove, because you will be double gloved, only on the outer glove, and they're going to pull it down as best they can without touching your under glove. That way, now this is trash, and they will remove that, and now that is still sterile because that was underneath your other glove. So now the circulator will open up a second set of gloves for them to place on top. So now you're back to being double gloved and everything is totally sterile. So if you contaminate your glove, it has to be the circulator that removes it while they are wearing exam gloves.
I have seen concepts bring that up. They'll bring different scenarios and they want you to recognize that you cannot change your own contaminated glove. Real world versus the book. We're going by the textbook, okay? Now, again, you announce, hey, my glove is contaminated. You stop movement in most cases if you can. A lot of times your case is still going on, okay? You stabilize your hand. So you have your hand out for your circulator. If you notice, she didn't grab it and let it splash, right? Because keep in mind, especially if it's during the case, there's blood, there's bioburden, there's all kinds of stuff on that glove. So she's going to also be mindful of making sure that she's not grabbing it so that that snap sounds. You know, if you've ever had a rubber band and it kind of snaps, that can happen with those gloves. So she's being very purposeful of how she's removing it, okay? And once that contaminated glove's off, you are completely sterile. So like, let's say the surgeon needs something, you can grab it really quick. But you still want to make sure if you're a double glover, I'm a double glover, that you're still going to have to put on that second set of gloves. Okay? But identify, speak up, present your hand for your circulator. Your circulator will pop up some new pair of gloves so that you can be back double gloved. Okay? Does that make sense? Okay. You guys are going to be ready when you get into the lab. Now, of course, this video for some reason is not playing, but that's okay because there's no sound. So, okay. So at the end of the case, we have to remove our gown and gloves. Okay. You started with everything being completely sterile. Now we have to think about what is the best way to remove our gown and glove. There's two ways. Now, per the book, you are going to pull the waist, because remember, you are tied at the back of your neck and the back of your waist. Just so you know, there's two ties, okay? Because you wrap around your waist. So you pull from the waist, you pull from the shoulders, pull down, roll, and then remove your gown. A lot of people will move the gloves at the same time. A lot of people will keep the gloves on to kind of clean up their sterile field, and then skin to skin, glove to glove. Okay? That is the proper way so that you're not bringing all that stuff all over your body. And I'm going to find out, this site might have just taken out. I'll find another video so you guys can really see it. So I will send that to you via Moodle this evening. I got to try to find why this one isn't playing so that you can kind of like literally be like, okay, that's what she means. Waist, shoulders, roll, gloves. Okay. This is that final act of safety. Sterility does not end when the case ends. You may see that somewhere. So I will repeat it. Sterility does not end when the case ends. Contamination control continues until you are fully out of that PPE. The other thing I want you to notice is she's wearing her eye protection. The circulator's wearing that eye protection. That is a must. There are many cases where you may be thinking, oh, nothing's going to happen. Next thing you know, someone's going to the eye station because something splashed. So you definitely want to have on your eye protection. For those of us that wear glasses, they do have like the eye shields. I tend to still wear the masks that have the protection with it just because it's easier. Depending on the facility, you can also bring your own eye protection, okay? But again, you'll get more details once you guys get into the lab and then get ready to kind of go out into your clinical settings, okay? All right. Now, we're opening our case. You are no longer the scrub. We are the circulator, okay? We have to protect sterility without being sterile. And this is very important because there are times where, let's say you are a runner and you're not the scrub person, but you're helping, okay? Look carefully at this setup. Something is definitely wrong. Your job is to find it. Was the 1-inch border respected on this in this setup? It's not. Why is the 1-inch border non-sterile? Because someone already saw the drape. This is hanging over. So there's edge contamination. So the wrap manipulation is past that zone. Anything inside the border must remain untouched, right? We don't want any of these things coming out and falling over. This is contaminated. A lot of times what I tend to do is we have extra towels. I'll grab the side and kind of like just slide it off of my field, so that it's not even out of, like, I'm not even in doubt. Like, I'm throwing it out, okay? Now, when we look at the proper method of delivering supplies, you kind of try to drop them without reaching in. You're opening away and you never want to hover over the field. Reaching over any of this, like reaching in over this, it makes sense, right? Like anything could fall off and contaminate through gravity and in shedding. The other thing that the chapter does talk about is the table height. Below table level, right? So it's contaminated. Remember gravity? And remember, nobody's down there watching underneath the table level to see, that kind of looks sterile. Like, we're not doing that, okay? Sterility exists, again, only at table level. And I'm stressing that because I have seen this concept show up on the cumulative exam and this week, okay? Sterility exists only at the table level. Okay, so we have infection control and us as the CST. Going back to micro, we know we can't see pathogens, right? So we manage the process. Goes back to that chain. We don't fight microbes directly, but we do stop their path. We get this chain that we see in front of us, okay? Infection requires a chain. We break a link, infection stops. So what is a source in the operating room? It could be the patient. It could be our team members, our equipment. Sometimes it could just be the environment itself. And keep in mind that organisms live on skin, on instruments, on surfaces, and unfortunately in fluids. Pathogens leave through blood, secretions, droplets. This is where we live, okay? We are washing our hands. We are making sure our instruments are sterile. We are monitoring our airflow. There is a traffic pattern that we adhere to when we're in the operating room, and we are paying very close attention to our gloves, making sure that they're not contaminated. We control that part of the link. Okay. So I want to do this one because there are common breaks in technique that I really wanted you guys to see. So here's the rules, okay? Do not fix anything yet. I want us to just kind of name the error so that we're now trying to train our eyes, okay? So we get to this gowned individual over here. What is wrong with him? Just at first sight, what is wrong? His hands below, they should be near his chest. Yes. Hands are below the waist. They're not even clasped. He's standing too close to the sterile field. If you notice, he has his back right up. And remember, the back is not sterile. His back is right up against the sterile field. Look at his PPE. Is there anything he's missing? I just mentioned it. Yes. He does not have on his eye protection, and his body orientation is not where it should be. Okay? All right. Now let's get to image 2 right here. We have a wet field. What is wrong with this particular drape? Yes, it's wet. You're going to hear terms like strike through contamination. Okay, so it's contamination. It is contamination, but when you hear strike through, I want you to be thinking about this image right here because that's what they're talking about. And I'm stressing that because y'all know how these questions are, right? So when you see strike through, just remember, okay, something is wet. The drape is wet. Strike through, wet. There's moisture breach. The area is wet. Okay. Now, moisture is dangerous because bacteria travels through fluid. And what better way to get closer to an incision site than having moisture right there? Wet equals contaminated. Okay, just another binary rule, like obsolete. Now, for the last one, this is one of my biggest pet peeves when I'm in the lab. Okay, what rule is being violated here? 12-inch rule is definitely being violated. But what else? Yes, that is my biggest pet peeve, y'all. Walking between two sterile fields. When I'm in the lab, I'm like, don't walk between two sterile fields. Don't walk between two sterile fields, okay? Because that's a big one. You're walking between two sterile fields. So you have sterile area, and a non-sterile person. Anything could happen, okay? Also, turning your back to the sterile field, and this is not really a good traffic control. What should happen is those fields need to become together, and then traffic goes around, okay? So just kind of keep that in mind because here sterility is lost between the tables, definitely below the table level. And you don't really have a way to determine, well, this side is okay, that side is okay. Would you call the table mayo stand as well? Yes. And I'm glad you brought that up. Any two sterile field. Sometimes you may have instrument sets that are on, per the book, the prep stand. Real world, we do not touch the prep stand, but you guys learn that. But per the book, your instruments are on your prep stand. So you may have your prep stand, you may have instruments like your back table, and you want to make sure that you are bringing them close together so that people are walking around and not through, because that is your field. Okay, so just kind of keep that in mind. But excellent point and excellent question. All right. Now, you guys do have a Quizlet. It is already up on Moodle. So it is just all about surgical asepsis. For those of you who are here, let me just give you the link again so that you guys can kind of have it. Additional resource, straight from the chapter, just different concepts to help really bring this together. You guys will receive that video because I want y'all to see how to remove your gown and glove. And I'm going to try to find a better video of the drawing so you can kind of visualize that too. So be expecting 2 of those this evening. No pressure, y'all, to kind of watch them, but I just want you guys to have them so that you have it when you guys start getting prep and ready for the lab. I'm like so excited for y'all. But as you guys get ready for the lab, because that's going to be some of the very first things you're learning, gowning and gloving, okay? Because, and setting up your instruments and stuff like that. So you will be expect those this evening, okay? This is how the rest of the, like, now that we're past week 5, a lot more videos, okay? Because I really want y'all, or we really want y'all to be able to visualize exactly how and what. So when the questions ask in different ways, you have that image like, okay, wait a minute, I saw this, okay? Biggest thing is doing the right thing for the patient when no one is watching. We all always come back to that surgical conscience. This is not about rules. It's just about who we are as CSTs. Every sterile decision that we make, it does affect the wound healing. It affects how our patients recover, how long they have to stay in the hospital. And sometimes it's survival, especially when you're in those cases where, like, we're holding our breath to make sure that we're finding that bleeder, we're clamping that artery, we are getting the patient back on bypass and watching that heartbeat again. Those are those moments where you're like, okay, I got this. We did that. The thing is, the patients never see the sterile field, but they live with the outcome. Okay? For those of you who are watching the playback, how can we balance the need for strict aseptic practices with the potential for human error in the operating room? Remember, to err is human. In what ways can the surgical team maintain a very high level of motivation and accountability for infection control, especially during those long, let's say, scoliosis cases, sometimes tethered spine cases where you're like 12, 14, 16, 18 hours, or even routine procedures? And how might the design of a surgical instrument and environment be improved to further reduce the risk of contamination during procedures? What questions do you guys have for me? Something does come up, y'all, please do not hesitate to reach out. We're at week 7. We've got 4 weeks left. And I really want to make sure that we are answering every question. And keep in mind, you may have a question someone else had too and they didn't realize it. So don't hesitate. Okay. Biggest thing is, now that we're over that hump, continue to train your eye. And remember that your surgical conscience, again, protects patients long after the lights that you see appear go off. With that, you guys, this is a long weekend, right? Right? This is a long weekend. So with that, you guys have a wonderful rest of your evening. Have a safe weekend. And I look forward to seeing everyone who can attend next week's live session. Good night, everybody.